Shital.
Rashminma is there.
She will present us Squint and Neuro ophthalmology, Dr. Shital. Shital works with me and she is a wife of Dr. Sumit. Go ahead, Shital. Rashmin sir, that is your case. Yes.
Good evening, everyone. Today I'll be presenting a case on neuro-ophthalmology. A 10-year-old male child brought by parents with complaint of headache and decrease in vision since last 6 months, more since last 3 months. That was right eye more than left eye. So they consulted locally, and child was diagnosed of having myopia, and he was prescribed glasses. That was around -5 sphere in right eye and -4.5 sphere in the left eye. Still, headache was not getting resolved, so he consulted elsewhere. This is the fundus photograph which he carried along with him, so which was suggestive of bilateral disc edema, and along with that, we can see exudates at the macula, that is macular star, and patient was diagnosed of having neuroretinitis, and he underwent investigations for the same. So Bartonella IgG and IgM were negative. VDRL was negative. Chest X-ray within normal limit. Montux was negative. Still, patient was advised oral steroid. He completed course of oral steroid, but headache was persistent. And there was non-resolving disc edema along with macular star. So they suspected idiopathic intracranial hypertension. MRI was advised. MRI was within normal limit, and then ophthalmologist advised him lumbar puncture. At that point, patient came to us for second opinion. These are the examination findings. Right eye best corrected visual acuity was 6/18 and 10 with -5 sphere, and left eye was 6/9 and 6, not improving further than that. Rest anterior segment was normal. Pupil, both eyes sluggish reacting to light, no RAPD. Fundus was suggestive of disc edema with multiple exudates around the macula, suggesting macular star. This is the fundus photograph. I'm really sorry for the glare. In this picture, we can see blurred disc margin, though macular star is not clearly visible, but it was there. This is the OCT disc picture, which was suggestive of disc edema. And macular OCT suggestive of macular edema along with the exudate. I'd like to ask the panelist, what will you do in this case? Would you advise repeat MRI? Would you advise some other investigations, like do you want to rule out a typical optic neuritis or something like that? And is lumbar puncture necessary in this patient?
Rashmin sir?
Yeah, so I think there are few things from the history point of view that you will consider. You have a long history of 6 months with 3 months of continuous progressive loss of vision.
Yes.
So confusion, of course, here is that are we dealing with inflammation, which is neuroretinitis, or are we dealing with something else?
Yes.
From the history perspective, neuroretinitis generally would not behave this way, or any optic neuritis would not behave this way.
Yes.
There is an inflammation. There are two possibilities. With your treatment or without your treatment, inflammation will subside, patient will improve.
Yes.
With your treatment or without your treatment, inflammation will continue, will attack the neuronal cells, there will be axonal death, patient will optic atrophy. And generally this process completes within 6 weeks to 2 months. Now what you have is a 6-month history with a 3-month, following 3-month thing is where even the other person would have thought of lumbar puncture.
Yes.
And I would like to do lumbar puncture, whether it is IIH or not, we don't know right now.
Yes, sir.
The factors pointing towards increased intracranial pressure is persistent headache and non-resolution of disc edema. There is nothing happened to disc edema, those steroids also was given, right?
Yes, oral steroids were given.
Yeah, but
yes,
I mean, with
given.
some treatment, by 2 months, I would have expected this disc to become normal. So we now are looking for some other cause.
Okay.
So is it hypertensive retinopathy, though there are no other features, or is it raised ICP is what we are looking for? So I would have thought on those lines and maybe ask for lumbar puncture, because we don't know whether this is, and in fact, even if it's an atypical inflammation, lumbar puncture, the analysis of CSF will have.
Okay.
Dogra sir?
I think you did talk about the hypertension. Blood pressure has to be taken because sometime if there is a renal involvement, we might have a lot of exudation and situation may be because of the accelerated hypertension. And another thing which I would like to do before going for lumbar puncture is the fundus fluorescein angiography, because that may give us additional information. Sometimes this kind of exudation I have also seen in cases of Irwan, which is very typically seen like that. So I think that can only be picked up once you do an angiogram, because you will see those knots in the arterioles. Those are the aneurysms there. So these are the, in addition, before going on to, I would like to.
And the one more clue is that with all this history, vision is not too bad. It's not like 1 by 60, it's 2 by 60. It is still holding on.
Yes, 680.
Jagatram sir, please come on the dais. I think I think when such type of case comes to you, better to investigate, and investigation only can give us a clue. So that is very important. I think both you are correct. So
I'll go ahead.
Yes.
So in this patient, we just did, as almost all investigations were already done, we just thought of checking his BP, and BP came out to be 250 by 120 mm of Hg. And on detailed history, parents give history of frequent urinary tract infection. Patient was referred to pediatrician and nephrologist. There he was diagnosed of having chronic kidney disease stage 3, secondary to reflux nephropathy grade 5 and hypertensive emergency. He was, they repeated his MRI, which was suggestive of posterior reversible encephalopathy syndrome. MR angiography was normal. Patient was admitted for 15 days. There he was started on treatment, and patient reviewed back after 1 month. That time he was symptomatically better, though vision was same, like right eye was 618, left eye was 6.9. This is the fundus photograph in which we can clearly see disc edema is now resolving, and we can clearly see macular star. OCT disc also confirmed the same. This is the 6-month follow-up of the same patient. Here we can see pallor is clearly set in and resolving resolved macular scar, almost resolved macular scar. BCVA of both eye is almost 612 by N6. Now there is no headache, and BP is well controlled, that is 100 by 78 mm of Hg. This is the OCT disc, which definitely suggests now RNFL thinning because of pallor. Normal OCT.
Go behind. Now Manish, disc. Now Manish, my another question is, when you get the OCT, now what has happened when there is a glaucoma or anything, we go for OCT. And when there is a problem of the optic nerve, there also you get the changes in the OCT. And once the changes are in the OCT, then the general ophthalmologist can think this is a glaucoma, they start the glaucoma treatment. Now, how to differentiate OCT of the optic nerve disease and OCT of the glaucoma?
So that's a very, very important point, sir, that you have pointed out, because now you have worked up all this patient, Shital has worked up, and now this patient comes to me for a second opinion that because of some ophthalmologist sees the optic disc pallor and does the OCT, which shows thinning of the nerve fiber layer in both the sides. And if you see that it's following typical glaucoma picture, so you will definitely point this disc as an abnormal disc. Then obviously when we do all the tests, first of all, if a child of 10 years comes with this kind of a picture, and if I check the pressure and it is normal, first and foremost, there isn't any great reports of normal tension glaucoma in children. So pediatric normal tension glaucoma is not a very established entity at all. So first I would not think of that. And if this is patient has just come, no history available, then I would investigate neurologically only for this patient. And second, supposing this patient somebody comes with similar picture who is in the older age group where normal tension glaucoma can occur. So definitely we will do fields. You have to watch. Glaucoma means is something you have to all the time look back and watch. Means you cannot ever be sure that this is not glaucoma. So I would say that all these cases which are on the border of optic disc appearance are what we call pre-perimetric glaucoma or normal tension glaucoma pictures. Unless they are threatening fixation, we don't immediately label as glaucoma and start treatment. We put them as glaucoma suspects. And there are a large number of patients who fall in this category. And you have to explain to the patient that this can be a thing which is not going to cause a problem, but it can be. So we need to know which category you are falling in. For that, you are going to come for tests to me and see me again and again. Of course, at the baseline, you have to do the full workup because you cannot be sure that this is not glaucoma. But in this case, 10 years age, I would not be that particularly concerned, especially if IOP is normal.
Dr. Manish, can I ask one question?
Yes.
So, would you consider some features on OCT as a telltale mark or maybe suggestive towards more glaucoma?
So there is the ganglion cell layer. If somebody was attending the last talk in the last lecture, session here, that person who failed to mention that one very important sign which is there on OCT, on ganglion cell analysis, and that is the horizontal line. When you get the ganglion cell analysis and you see a horizontal line which is extending to more than half the length of that analyzed area, so that is basically indicating the horizontal separation of nerve fibers which exists and which is the telltale sign in glaucoma. So if you see that, then that is a very good sign for you to, think that this damage is occurring with the ganglion cells and the nerve fibers are getting affected before the disc got affected. Because this patient has this defect, but this has originated from the disc. So it's not going to follow exactly that pattern. But that test has not been done and we don't have that data in this case at least.
Yeah, and I think from the neurological perspective, especially like somebody who has a pituitary tumor where OCT has a role to play, you will have a very clear binasal, prepondering binasal involvement corresponding to bitemporal hemianopia.
Take-home messages. Eyes are not only for the vision, they are the windows to your health. Thank you.
Thank you, Shital. I think what expert says is very true, that OCT, once you are doing OCT, in that, if there are changes in the OCT, yes, it is if it is like a pediatric child with a normal tension, then in such cases we can say no. But in the other situation, you will have to do perimetry investigations, and after everything, again we will have to do follow-up. Because without follow-up, then what happens? Then if there is a glaucoma, it progresses so far, and then there is a problem in the vision. So it's always better to follow the patient when it is such type of finding is there. Thank you. Thank you very much.